Right, good afternoon or good morning, depending on where you're located, to everybody. Thank you for the kind invitation and having me here. First of all, my thanks goes to Riccardo Dizio for putting together these unbelievable initiative and the Harvard Medical School with the Global Health Catalyst. I think it's such a great opportunity for me to speak about surgery for older patients with cancer, and I hope we can enjoy the next 45 to 50 minutes together. Feel free to interrupt me and ask questions like via the meeting app at any point, so we can also make it a little bit interactive. I am a colorectal surgeon. I work in Faenza, Italy. I'm also a member of the European Society of Surgical Oncology and one of the members of the International Society of Geriatric Oncology Surgical Task Force. I must say that I have, unfortunately, very little to disclose. I do have a couple of disclaimers. First of all, I'm a colorectal surgeon. Around 60 to 70% of my practice is dedicated to older patients with cancer, which is usually colorectal cancer. So several of my examples today will be specifically for those, regarding those type of people. The second disclaimer I have is I'm absolutely passionate about care of older patients. It's something that started in me about 10 years ago during my PhD. And I have this thanks to Riccardo Dizzi again, who totally affected me with his passion for caring for older patients. I think this is an incredibly important topic nowadays. It's not just important because the Western or the global society age is increasing, but also because we have now a specific generational gap that we didn't have in the past. There's always been a gap in between generations across all eras, but this specific moment, because of the way we communicate one another, this gap is getting bigger and bigger. And we do have our own issue in communicating one another. And God forbid to communicate with somebody who's so different from us and has so different expectation for what we might have or what we think they should have. And I think this makes this specific time and this specific setting so important for all of us that are in the healthcare. I'll try to highlight why I think that the care of older patients is so important today. And one of the reasons it's so important is because we have been performing very poorly. The reason for that is that we are carrying on several misunderstandings, but we do have a need to make it better. I'll quickly highlight on what I think that makes things better or might make things better, which is like focusing on functional recovery and patient-reported outcomes instead of the usual cancer care outcomes, and what I consider the real issue going forward, which is value-based care. As you all know, we are in a moment of time where the global population is aging. And this is not just affecting Europe and the Western country, but the entire world. And the percentage of people who will be over than 60 over the next 20 or 30 years will be increasing more and more. And number-wise, this may even more impactful in the south of the world than in the north of the world when this number is so large nowadays. Why it's so important to acknowledge that the population is aging? Because the way that people die has been changed. And if we look, for example, of causes of death in England and Wales, and over the last 100 years, we saw that infection that was the #1 killer has been replaced by cancer. So it has been replaced by something that we try to deal with every day. And this is regardless for male or females. Again, we're shifting the cause of death from something that we did have or we didn't have a way to care before with something that surgery can be an impact on. It's so important because the majority of surgical patients that we see every day are old. And the problem with that is not just like an epidemiological data, it's that like as a scientific society, we're not able to put together very good quality data when it goes to the care of older people. And so this is the kind of a hot, silent topic that is gaining more and more attention during the course of the last 4 or 5 years because it's so impactful in everybody's practice. The problem is that we're not just seeing more older patients, but the old patient do have special needs, and those special needs translate in higher resources that needs to be allocated to them in order to take care of whatever condition they have, and cancer specifically. While we're not ready, unfortunately, in our system to take care of these needs, standing on the actual statistics that we see every day. Why do I say that we're not ready? Because data are showing us this. If you look at this specific manuscript from the European Journal of Surgery by Rebecca Birch, you will see that a lot of patients that are age over 80 have failed to receive the optimal surgical care. And this, again, is not an opinion, is a fact, is a piece of data. Despite the fact that older patients are better equipped to go over or cope with difficult situations, as has been shown also by this manuscript. The less surgery that we offer to these people, unfortunately, translate in worse cancer care. And there is a clear unfavorable cancer-related survival among all the patients if we look at every organ, but specifically the GI, so rectal and gastric cancer. Again, this is data that are in front of all of us. And this is not related to age. This is not related to comorbidity. This is related to unfavorable cancer-related survival. Same data has been again confirmed in the UK. Now, why it's so difficult? Why do we have such a poor outcome in treating older patients with cancer? It's because when we face a young patient with cancer, it's like being in front of these control. You only have one button that you can switch on and off. But when you take care of an older patient with cancer, you have so many dials that you can work with or you have to deal with that the whole situation become incredibly more difficult. This is not just because patients are difficult, but also because we have been performing very poorly in advertising and showing what we can do when we go to surgery and treating cancer surgically for older patients. This is just an article from the New York Times from 2013, and it was basically entitling Avoided Surgery in the Elderly. This is the message that comes through. If you are of a certain age, you will not receive the best possible treatment because no good reason. And unfortunately, these kind of things that comes through the press sticks with people, and even with healthcare provider. Those are two surveys from France that were basically saying that only physicians' attitude was the reason why people were not receiving the proper cancer treatment, because even physicians consider chronological age as a factor to not refer cancer patients to cancer specialists. And this is pretty outrageous because it doesn't come just from primary care physicians, but also for cancer-focused subspecialties like medical oncologists or radiation oncologists. Now it's time to stop saying, or stop talking, as my friend Armin Shoroknis used to say, about age alone. We have to shift into a new paradigm because age is really just a number. Why are we performing so poorly? And why we cannot move from considering age just a number? The reason why we've been badly dealing with this as a surgical society is because we are still struggling in differentiating biological age from chronological age. We do understand that the great Pete Frates, who unfortunately recently passed away, was absolutely frail in his last years of his life, despite his young age, as compared to this random Italian gentleman that I met at the cafeteria who's still living his best life, as you can see from his outfit. The problem is that we don't know what to do when we have patient that looks frail or that might be frail, and what kind of treatment offered to them because of their frailty. The reason for that is because, again, as a scientific society, we haven't been able to produce evidence that are solid enough in order to specify and to detail the type of treatment that we should allocate to these patients. And this is the biggest misunderstanding of all. What are we doing as a scientific society is basically generating a research trial that are focused on a group of patients which are usually not older than 65, because this is considered some very often an exclusion criteria, and then generating an evidence in cancer treatment, and then translated whatever evidence we generated from that specific population of healthy individuals into the people that we say every day in the clinic, which are not young and are not fit. And guess what? We don't have the same outcomes. Now, the first misunderstanding, going specifically into details, is because we have been perpetuating these things that cause randomized control trials. And it's not that randomized control trials are bad. This is like a good way of creating and generating research data. But the problem is that they don't apply to every single setting. There's no need for randomized control trial to just suggest that maybe flying out of an airplane with a parachute is better for your life than do it without it. But again, this may not be the way to study what we can or we cannot do in this specific population of older patient. While observation, and so observational study, might be maybe a more interesting way to act. The second misunderstanding is that we are not really looking at epidemiological data. And this is nothing new. This is data from 20 years ago. They were showing us already that if you are in your 80s, your life expectancy is still of 10 or 13 years, depending if you are a male or a female. Now, if your condition is not perfect and you're not fit, and you start having comorbidities, your life expectancy may go down to 5 or 3 years, but still 3 years is a pretty long amount of time when you're 80. Why it's so important to understand the role of life expectancy? Because this mixes with the role of surgery and with cancer surgical care. This is a very interesting graph to me. And you can see that we have life expectancy along the ages, and we have a solid line that shows the percentage of people dying within 1 year at a given age. Then you have the broken line that shows you that was the percentage of people dying at the given age after rectal cancer surgery, and those are the historical data. Now, what minimal invasive surgery and increasing the protocols for postoperative enhanced recovery did to our population is that they pulled that line down closer to the healthy people. So that's showing that surgery is not just safe, but can make people go back potentially to a status of complete health. Because the percentage of people dying now after modern rectal cancer surgery resemble pretty much the one that were coming from the general population. Now, when I look at rectal cancer and older patients, the first thing that comes to my mind is disparity. And this, for example, shows the disparity of 5-year overall survival among rectal cancer patients. And if you look specifically at the stage 3, so those patients who really needs multimodality treatment, you will see that by the time that you treat those patients only with surgery, you will have outcomes that are increasingly and dramatically worse than younger patients. But if you define a group of patients that can go through multimodality treatment, so for example, chemoradiation before surgery, and you compare them to the younger group of people, you will see that this gap gets incredibly smaller. We can obtain great results finding the good patient that are good candidate and giving them the right treatment to cure their cancer. Now, again, the problem is that we need to identify which are the patients that will benefit from the proper cancer care to the one that will not able to survive, not the disease, but our treatments. And now we need to introduce a new concept again, which is called frailty. And frailty really is a state of a patient that comes to you, and when you're up to offering treatment, you have to realize that whatever you're given will kind of decrease their ability to go back and be functional again, up to a point that this decrease and this dip can go into complication state. Now, if you're fit, you may be able to come back to whatever status you had before whatever treatment you're receiving. But if you're frail, you may not be able to come back again. And so we really need to think which kind of patient we have in front of us. And so we are at the point that even the New York Times figured out that it's no longer a problem of age, it's a problem of frailty. What is frailty? If we know something about it, it's because of the great amount of literature and studies that this man, Ludovico Balducci, put together. He's an Italian man who worked his life in Tampa, Florida, and really is one of the father of aging and frailty. He defines frailty as a decrease in functional reserve up to a point that whoever patient becomes disabled. And after disability, it's functional dependence. And here is when you're frail. At this point, treatment may put you to the very bottom of the curve instead of making you able to gain your functional reserve again. As surgeon, again, we don't want to look at age anymore. We want to look at frailty. So how can we assess frailty simply in our clinic? What do we need to do that? We're not geriatrician. We cannot do a full geriatric assessment because that's time consuming, and it's kind of against like everybody's practice to like allocate so much time over one type of assessment. So we need something that is brief, quick, but it's also something that will help us identifying those patients who are at risk that might need then a full assessment by a geriatrician. And so identify which kind of intervention we can do before the surgery. When we wanted to screen for frailty, we need to realize there are at least 4 domains that we have to understand and assess: mental health, medical condition, function, so if the patient is able to walk or not, but also social status, because those patients, they don't come alone. They will have the need for care, and we need to realize that there must be somebody helping them when they go back home. Now, all guidelines from every society tells you that care for older patients comes with frailty screening. Unfortunately, this is not true in real life. This is a study I like very much because it's a real life study and has been done by few observers at the cancer center attending what they call the multidisciplinary meetings, where all the specialists are gathered together to discuss cancer care. And when it was going to patients that were older than 70, you will see that while cancer specific were detailedly described by radiologists, pathology, surgery, when it was going to specific frailty, everything was described with no specific general descriptors, such as well, good, maybe fit, very poor. The problem is that all those ambiguous descriptors are, and non-objectives most of all, are the ones that shifted the cares toward one way or another. So again, we don't accept cancer discussion without state-of-the-art CT scan, MRI, but we do accept to take care of patient without a clear objective description of their own status, of their own frailty. And so we may not understand that the patient on the left is so frail and vulnerable that maybe he will not even survive the treatment for a small cancer, while the guy on the right is so fit that maybe even something that is way more invasive and way more dangerous can be treated on him because he's willing to accept and he might be able to survive advanced medical and surgical treatment. So for this reason, we tried to put together a group of experts in 2017 from the European Society of Surgical Oncology, the European Society of Coloproctology, the International Society of Geriatric Oncology, and American College of Surgeons Commission on Cancer, and find out what we thought was the key to start shifting the paradigm from age alone to personalized care of older patients with rectal cancer. And one of the things we decided immediately is that frailty and non-chronological age should have been used as a risk certification in order to define what kind of treatment a patient may or may not have. Now, if you have to answer this patient, the only one and true question they will ask you, then of course you understand that you need to have more data than your gut feeling. The problem, again, as surgeons is that we live a busy life, we see a lot of patients, and we need to understand how to decide if a patient is fit, vulnerable, or frail, so if he can undergo a full treatment or a more personalized care. And the two tools we have been struggling with over the last 10 years have been the very time-consuming, but of course very effective, but not reproducible in a surgical clinic, comprehensive geriatric assessment, and the very shallow American Society of Anesthesiology score. Now, as surgeon, there are tools that we can use in our own clinic, regardless of the part of the ward that you're located. But we have to go back to the basics, because sometimes we forget to talk to patients, and sometimes we forget to ask them the important questions. And one of them is very simple, like, have you fallen? Why it's so important? Because, you know, if patients fall before surgery, these correlate dramatically with the risk of complication. And you will be shocked if somebody has fell more than 2 or 3 times, the risk of postoperative complication goes from 60 to 100%. This is pretty hardcore data. Another very simple test to do, again, in every clinic, is what is called a time up and go test. You basically ask your patients to sit and to stand and walk 3 meters, come back and sit again, and you time it. And again, we have data now that shows you that if it takes more than 20 seconds, then the risk of postoperative complication is significantly higher. And when comparing the time up and go and the results of the time up and go test with the more sophisticated comprehensive geriatric assessment, we found no difference in accuracy of predicting postoperative complication. So again, something simple, something we can do in every clinic. Now, if you want to be more fancy or sophisticated, which is probably the way that we will move towards in the next 5 to 6 years, you will see that there's like way more that you can do. And what is called the epigenetic clock has been wisely described by Sarah Hug as one of the best predictors for postoperative mortality in older patients. And I really advise you to read the last manuscript of Sarah published on the European Journal of Surgical Oncology, specifically on this topic if you're interested in it. Now, going back to our frailty assessment, we wanted to do something that can really lead our care. So we're not just like screening patients for the sake of like knowing how frail they are, but because we wanted to titrate our care based on those data. And this is what we offered and generated on our consensus. So we wanted to use simple tests like the G8, the time up and go, and the mini-cog, which is a very quick cognitive assessment, and the numbers of fall, in order to understand if a patient is absolutely fit for surgery or if he or she is not. And what we saw is that if one of these scores was impaired, then the need for a full geriatric assessment is absolutely guaranteed. And also, we wanted to have a geriatrician involved in the MDT care, because they are the one who will advocate for the patient and to personalize the care in case of need. And this is just an algorithm that we generated for rectal cancer patients. What I wanted to really highlight is that, again, based on the preoperative evaluation, you can really go through standard of care, or you can go through what is called adapted care. While adapted care is not a one closed way that, or road that you can take, you can always go back to the standard of care based on risk and benefit, and based on the ability of the patient to improve their function before the surgery, what is called prehabilitation, that we'll briefly discuss at the end. It can, again, take you to the standard of care. But again, standard of care is not the goal. Personalized care is. And so there are so many options that you can put in place in order to treat rectal cancer in older patients, like local excision, chemoradiation, and then watch and wait protocols. So many things are in place. The problem to personalized care is that you have to realize that you have a person in front of you and you want to understand as much as you can about this person. Now, there's no setting where frailty assessment cannot be performed. There was once a huge question about the emergency surgery and how this environment will be absolutely inappropriate for frailty assessment because of the rush and the situation and the altered mental status that several patients may have because of acute peritonitis, because of trauma, because of several complications that led them to emergent surgery. Now, this is no longer true, and we have shown that using the Flemish score. The Flemish is just a triage risk screening tool that is based on 5 simple items that can be always provided, either by the patient or the caregiver. And it's cognitive impairment if the patient lives alone, if the patient has difficulty walking, he was in the hospital or she was in the hospital in the previous 3 months, and if she is taking more than 5 medications. Now you will see that the Flemish score is absolutely correlated with postoperative mortality and postoperative morbidity, while, for example, age was not. And this is very interesting for us because, again, it shows you that age is just a number, and frailty instead is what should drive the care of these patients. While the Flemish was not only able to correlate with postoperative complication, morbidity, and mortality, but also with patient functional loss, and correlated in case of a score greater than 2 with patients who decline in their activity of daily living after surgery. And remember that length of stay with more than double in patient with an increase with a greater than 2 Flemish stress risk screening tool score. Now, what's the key point of that? First of all, the Flemish allows you to really screen for frailty even in a complicated environment such as emergency surgery. Second, it may lead you to ask for help preemptive instead of reactive. Help from who? Help from our friends the geriatricians, because those are the ones who should help us taking care of these older patients, because they have a better training and a better mind when it goes to take care of older, frail individuals. But then also it could help us to set expectations, not just with patients, but with their own families. And this is so crucial, above all in the emergency setting, when everything is rushed and people are confused or not able to give firm and solid assessments. Now, if you wanted to know what kind of geriatricians you need along the way, I have the answer. You need somebody like Armin Shorokny. He's a great man, a geriatrician and a medical oncologist from Memorial, and he's one of the brightest minds in this field. And what I owe him forever is opening my mind about a new concept that is called geriatric co-management. Geriatric co-management is something very simple, and it tells you, surgeon, hey, in order to treat frail patient, you may have a frail specialist in your way, which are, again, the geriatrician. And he absolutely convinced me, showing me at ASCO last year, this data about his patient at Memorial, when he basically divided 2 groups of patients, one of 1,000 who underwent a geriatric co-management after surgery, and one who was managed by the surgical team alone. And as you can see, he was able to show that the patient who underwent a geriatric co-management has a 90-day mortality of 3.5%, that it was a third of the one of patients that were only managed by the surgical group, the surgical team. Now, those patients he highlighted had the same risk, had the same postoperative complication rate, but only the patient who were managed together with the geriatrician had a higher chance to survive. It really means that we really need these people on board right after surgery. Now, another problem, another huge misunderstanding they have been carrying on in this population is that we have been asking them all the wrong questions. We gave for granted that whatever we think is best for them is also their own opinion, but it's not. All the patients with cancer are rarely interested in outcomes like progression-free survival. They're more interested in something that is more solid, like, am I going to survive my surgery? And above all, am I going to be functional again after surgery? Am I going to be able to play with my grandkids or go or attend my granddaughter's wedding? Those are the things that really interest those patients, and those are the things that we haven't been looking at for in our study for so many years. Now, functional recovery is what we should focus now on in order to understand if our treatments are efficient or not, above all in this specific group of patients. What is functional recovery? If I have to define it, the first thing that comes to my mind is the great Franco Baresi. He's one of the best defensive soccer player in the history. He's Italian, and he was so iconic in 1994 when he injured himself in the second game of the round at the World Cup. Then he underwent his surgery, and he was so quick at recover that he was available again to play in the final. Then Italy unfortunately lost the game, and so Brazil was World Cup champion, but Baresi has been forever the champion in my heart when I think of functional recovery. Now, that was true up to the moment that I met my patient, that he's 79 and he underwent a colectomy, and 13 days after a major abdominal surgery, she was able to go with her bike for 50 Ks. Now, when I think of functional recovery and somebody going back to their own active life, she is the one that I'm thinking at. Functional recovery is it's a concept that it's simple, but it's hard to measure. And for so many years, we as surgeons has been thought of functional recovery as like an idea of length of stay, or like first flatus after surgery, or being able to tolerate food. Those are just like simple outcomes that don't describe function like deeply and inside in a way that it's meaningful for patient. For example, when I talk about functional recovery in rectal cancer surgery, I have to describe and have data about urinary sexual function, about fecal incontinence, but also have to look at less debated functional outcome, like the number of patients who will leave with the diverting loop ileostomy after a protectomy. Now, again, when I think of functional recovery, I wanted to link it to something that is related to regaining independence. And this is really a key indicator. But unfortunately, regaining independence is almost never one of the primary outcomes of our study. So do we have actual data? Again, when we met together back in 2017, we decided that in order to measure functional recovery, we need to start piling up data. And the domains that we wanted to study and measure should be the ability of people to go back to their active life. So we need the activity of daily living in order to measure that. See if the patient are able to walk and be mobile and functional again. So tests like the 6-minute walking test or the time up and go can actually be used to measure and bring data about it. But also we wanted to focus on mental status. And so maybe the mini call can be something simple that we can offer in the clinic to monitor our patient before and after the surgery and see if cognition is still on. And then the newest and very intriguing new data coming from studying sarcopenia. Now, sarcopenia is incredibly interesting to me. It only requires a CT scan, and what it gives you is not just an idea of the muscle that you have in your body. It gives you also an idea of the role of inflammation and insulin resistance and nutrition deficiency and all kind of endocrine function that is going on in your body. And this is why it will become, in my view, one of the key points that will be measured in the future in order to define not only frailty, but also ability to recover in this specific group of patients. Now, the problem is that we do know that sarcopenia happens very quickly, but we don't know how long it takes for muscle strength or muscle tone to be regained after whatever intervention we want to put in place. Now, keeping an eye that really functional recovery was something that our patient were asking for, and we as a group wanted to focus our study on, we designed the GoSafe study, which is only the third of a group of 3 studies that's being promoted by the International Society of Geriatric Oncology Surgical Task Force. This study has a specific primary outcome, quality of life, and functional recovery. It has been a study that took us 2 years, and we were able to put together 26 centers from around the world. And this was driven by the European Society of Surgical Oncology and the SIOC Surgical Task Force once again. These centers were mostly located in Europe, United States, and Israel. And what we showed very quickly was that, unfortunately, a lot of our patients after surgery don't go back to their function or to their preoperative standard. And this is about 1/3 of our patients. Now, if you're interested in measuring function and measuring outcomes that do matter to patients, no one but the ITROM group should be inquired. Those are a very interesting group of people that were able to standardize the outcomes that do matter to patient, to specific group of patient like older or colorectal cancer patient, so that all of us can be able to compare our results to whatever they gather. They really gave us a standard in order to measure outcomes that are interesting, that are important to our patients. Unfortunately, studying PROMs is complicated. It's slow progressing. It's very hard to measure with the instrument that we're used to have in our practice, because we don't have this type of questionnaires embedded in our own H&P or our own system of analyzing and treating patients in our daily life. And so all these outcomes have been for ages not evaluated and not studied properly. Now, unfortunately, this is kind of the key, because only if you understand what kind of results you have on the specific outcomes that matter to your patient, then you can allocate a cost per patient and eventually understand that what you're generating is a value. I wanted to allocate cost, I wanted to put money in something my patients are interested in, but if I don't measure it, there's no way I can pursue this type of care. Now, luckily, there have been a lot of studies that go safe, including showing that quality of life and functional assessment can be measurable, can be a feasible outcome in our daily life. When you look at PROMs, not all the glitter is gold. You have to realize that the way we measure PROMs is not that simple. On the left is the HCAP score that I used to give to my patient when I was a fellow at the Cleveland Clinic, Florida, with Dr. Wexner. And on the right is the unfortunate McDonald's customer satisfaction score. If you look at them, they look quite similar. The reason why is because they're both based on what they're called heuristic questions. Heuristic questions are questions that are designed in order to make a complex problem simple. Unfortunately, this really rarely works in healthcare, because if you have to describe how was Dr. Montroni with you, is he a good doctor? That depends on so many variables. It may so be different on a day or another, that again make the final assessment difficult to be motivated. Now, this is unfortunately the way that we have been not just developing our care, but scoring the level of care. And you can see that, for example, the overall hospital care that we measure as healthcare professionals has nothing to deal with patient satisfaction. While some hospitals are ranking very low in our scores, might be #1 in terms of patient satisfaction. And so you really understand immediately that there's something that is not completely square there, and there's something that needs to be evaluated more in details when it comes to PROMs. One thing that is sure is that there's so much that we can do in order to improve patient satisfaction and patient's care, so that both our goal and our patient's goal can come together as units. And one of this is enhanced recovery protocols. Those protocols are great, and they work even better for all the patient, as it has been showed. But why do we never think after surgery? We now have something, we now have a tool that allows us to do something good for our patients starting before the procedure. And this is called prehabilitation. If you wanted to read about it, please look at Professor Franco Carli's work. This is an incredible amount of information, and it will tell you that prehabilitation, so the amount of things that you can do before the surgery in order to arrive at the moment of the biggest effort in a better shape, are related to cardiopulmonary exercise, to nutrition, but also to psychological aids. And what is the best moment for prehabilitation is, of course, if you have somebody who has a planned surgery, so they can do something from the moment of the diagnosis, and they can improve their condition. And what they were able to show is that not only they improve their condition, but those patients maintain their better shape after the procedure, while a control group were never able to go back to their active life. If we look at Carli's work again, and going back to my rectal cancer background, you will see that the time of neoadjuvant treatment, it really gives us the optimal chance to have a moment in time when we can really give this patient a chance to optimize their status before the procedure. And now if we look at cancer-specific data and prehabilitation, and this comes pretty fresh, again from Franco Carli's department, you will see something astonishing, which is that cancer survival it's better in stage 3 cancer in this group of patients that had prehabilitation before their surgery. So it's not just something that will improve their chances of functional recovery, but also something that will improve our cancer-specific survival. Now, again, going back to square one, what we wanted to do is no longer generate some knowledge in the younger group of patients, but we wanted to do it for frail patients. We wanted to see if rehabilitation work in this group of patients, if our strategy may work in those group of patients, and based on that, titrate our care. Now, this has been the best announcement of 2018, and it comes from Denise Lecomte, who's the Director General of the ORTC. And it's so great because it says something that is absolutely true. Which tell us that as a scientific society, we've been always focusing on drugs, but as a surgeon, I could say on technique, on surgical strategies, and we've not put patient at the center of our care. And only when putting patient at the center, we will be able to define those outcomes that are so important to them, and we'll be able to focus on those. Now, the problem with putting drugs at the center of care is that you generate a horrible paradigm. You look at the 70-year-old patient with colorectal, had a right colectomy with no nodes, and you have on the left the patient put in the Memorial Sloan Kettering Cancer Center nomogram, and on the right, the same patient undergoing chemotherapy after surgery. And you will see a shocking decrease in what is called cancer-specific survival if the patient had chemotherapy. 48% versus 51%. How this is possible? We don't know specifically, but we know that allocating chemotherapy randomly to people may not be the right choice for everybody. We may need to understand better what kind of individual we have in front of us. And of course, we also have to understand cancer better. Now, if we look at this piece of data, and we know that 60% of patients are older than 70, and we just show that maybe there's not a lot of benefit in adjuvant chemotherapy, and also a large group of colorectal cancer patients, which is stage 1 and 2, that probably don't need chemotherapy, you will see that the key element goes back and must be surgery. And nowadays, as surgeons, we need to reobtain and regain our leadership in cancer care and really be more proactive in a way that we treat patients, in the way to communicate what we do, so that we can make people understand that we are an important piece when it goes to care of older patients. Now, in conclusion, I hope I showed you that the era of talking about age alone is over. We need to come from this concept of age to something that it's more important, it's more crucial, it's called frailty. Standardized frailty assessment is the key. It's a key if we wanted to change your standard of care and go to a more personalized way of treating our patient. Now, older cancer patients give us an ideal setting to do specific research on function recovery and quality of life, because those are the outcomes that are interested in order to promote a value-based care. Again, I think that research in older patients can change everyday's practice. And it's not just a way of creating new knowledge, but it's a way to create a better society and a better place. I highly recommend the March issue of the European Journal of Surgery. Will be fully dedicated to the care of older patients affected by colorectal cancer. It's a big effort coming from a number of authors from around the world. So I really hope you can read as much as I will and enjoy it. Thank you again for your patience, and thank you for having me today.
Thank you.
Thank you, Isago, for your fabulous lecture today. At this point, if anyone has any questions, please present them now.
Could you explain a little bit the difference again between frailty and old age, and in being able to take that into account when we plan for a treatment?
So the difference between frailty and what? Sorry.
And old age, and aging.
And old age. Well, like to me, it's like age is a number. Age is a number that it comes with you, but it doesn't represent you. It doesn't represent your condition. What we consider frailty is the level of understanding your own biology that correlates to whatever outcome you will have whenever we offer you a treatment. For example, we do operate on people who are in their 80s, but they go out and walk and are active and drive their car. Well, sometimes I'm afraid to operate on somebody who's 60 and already had like 4 myocardial infarction, COPD, not able to walk, obese. The second patient is frail. The first one is just chronologically old. Now, what kind of treatment can I offer to somebody who's frail? Now, this is a new discussion that we need to have at our MDT, which will no longer be, do you want to take care of this patient, yes or no? But also, can we offer him something that might be alternative, that be more respectful of their own biology and their own goal? For example, local excision for rectal cancer might be a valuable solution for somebody who's like 88 and has a rectal polyp that is about to turn into a cancer, but cannot go through a formal rectal resection. The use of watch and wait protocols after chemoradiation on those older patients is absolutely interesting to me, because it takes out like surgery from the equation, but I know that people can go through chemoradiation sometimes better than through a rectal like resection. So again, this is a new type of discussion that we wanted to promote, that we wanted to have, but we don't want to no longer have it based on just a number. We want to have it based on the condition. And there are ways to stratify that condition. These like number of falls, activity of daily living score, the G8, the mini-cog are all like small examples of the frailty assessment, which is what you want to measure, so we can have a proper discussion.